unfortunately, Dr. Kim unexpectedly won't be able to join us this morning, and he asked me if I would introduce Dr. Chan. It gives me great pleasure to be able to do so. It's certainly an honor. Dr. Chan will be spending the day with us this morning, and he is a PhD from Cedars-Sinai, where he is a professor. Our backgrounds overlap in that I spent some time at MD Anderson, and Dr. Chan was there from 2000 to 2004 for his PhD. Following that, he did his postdoc at Stanford. And this morning, he is speaking to us about cell death-induced mechanisms of therapeutic resistance. This is obviously a very important topic. It's a topic that certainly can benefit cancer patients. It's one that I did spend some time in a lab working on. And it's certainly humbling to see Dr. Chan's accomplishments. His team focused on investigating how aberrant cellular differentiation impacts tumor characteristics, subtyping, and patient outcomes, and how the interactions between cancer cells, cancer stem cells, and the ECM or immune microenvironment can be exploited for therapeutic targeting. This is certainly a very timely topic and one that's relevant for every single one of our cancer patients. It's a great pleasure to have Dr. Chan here this morning. Thanks everyone for being here. Dr. Chan.
Thank you very much for the introduction, and thank you for the invitation to give that seminar here right now. So today I'm going to talk about cell death-induced non-classical mechanism of therapeutic resistance. So as most of you, including myself, that we are all trained to induce programmed cell death as an anti-cancer therapy. And I hope to show you some data today that it's not as straightforward as we think. And there are definitely a lot of cell death-related biology that we should be looking into in terms of therapy. So I have nothing to disclose. So just want to convince you that my lab is sitting at the bridge trying to translate research from basic science into translational discovery. And there are three major programs in our lab. First, we look at cancer as a disease of aberrant cellular differentiation. And through that, we are part of an international consortium to subtype bladder cancer into clinical relevant subtypes. It hopes to convince you that it can be used as a prognostic marker for precision medicine type of research. And second part that I will talk about today is on cell death-related biology and how that we can exploit those as therapeutic targets for chemotherapy and chemoimmuno combination. And the last part I will touch on is about the collagen extracellular matrix microenvironment and how that can be exploited, and the biology, how it relates into the metastatic cascade. So from my lab, we always start with the clinical questions or using patient materials. And then we have developed multiple models, such as patient-derived xenograft, syngenic models, and organoids. And depending on the research question that we will use different types of models. So to this audience, I don't think I need to convince you that there are tremendous tumor heterogeneity in a patient at multiple levels. These include inter-patient heterogeneity, illustrated by TCJ type of study. That patients have very different genetics on multiple levels. And even within a patient, there's tremendous intra-tumor heterogeneity shown by historical data, as well as recent data showing that they are functionally distinct. And then when you stain with proliferation markers, as well as other differentiation markers, they are very distinct. So this caused cancer to be very difficult to treat, even within a single cancer type. So in the past several years, we are interested to understand how normal differentiation in the epithelium parallels that to cancer development. And you can see here that there are markers that define different states of the epithelial cells from stem, progenitor, and differentiated cells. And when we utilize these markers and apply them to patients, you can see that they distinctly subtype them or subclassify them into two major subtypes: the basal and the differentiated where the basal subtype highly express the same progenitor markers, while the differentiated subtype highly express the differentiated markers. And in a treatment naive setting, you can see that over here in the red line here, that the basal subtype correlate with significantly correlate with poor outcome. So our lab was one of the first to subclassify bladder cancer into different differentiated subtypes, and followed by TCGA and other groups. Now it's generally accepted that bladder cancer can be subclassified into two major subtypes. And this is data here summarizing the two broad classes of bladder cancer. So this is, we use biological bias driven classifier using only 18 genes of cellular differentiation. You can see it broadly subclassified into two subtypes. And the TCGA and other groups use so-called unsupervised clustering approach, also bioinformatically cluster them into two major subtypes. However, interestingly, when you look at the correlation to outcome, you can see that our classification method using only 18 genes that are biologically driven really shows as good, if not better, stratification, really suggesting that the biology using cellular differentiation might be a very interesting to drive the subtyping as well into clinically relevant subtype. And here, most recently, we further utilize, so most of these subclassical method only use mRNA or RNA-seq data on the one platform. And most recently, we utilize the TCGA subtype collaborate with a bioinformatic mathematician. You can see that we take advantage of somatic mutation, copy number variation, methylation, and integratedly subclassify them into, again, you can see two major subtype driving on here. And these two major subtypes have a high concordance with the mRNA subtype that we previously mentioned. So really, again, suggesting the biology of these bladder cancer driven by two major class of tumors. Of course, you can see that it can further subclassify into more granular subtypes, and which is the field is going toward. And we are very interested to see how these subclassification correlate with other treatment methods such as chemotherapy or immunotherapy. So I hope this first part of talk that I convinced you that based on cellular differentiation, we can subclassify patients and partially dissect the inter-patient heterogeneity. And we have also want to point out that there's signaling pathway driving these different subtypes. For example, we have found that a gene STAT3 that is very important for self-renewal of embryonic stem cells, driving the basal subtype of bladder cancer. We have developed mouse models to fully recapitulate the basal subtype of bladder cancer, which we don't have time to get into today. And also in our 2012 Nature Review article, we speculate that these two different subtypes are driven by a signaling pathway that are relevant for driving self-renewal, such as GFR, and also other pathways such as the PPAR gamma signaling that are known to drive cellular differentiation. And there are now data out there demonstrating that this pathway is important for basal, the EGFR is important for the basal. And TCGA and other data set now showing that there is gene amplification in the PPAR gamma pathway driving the differentiated subtype. So I really look forward to see how these information will be translated into the clinic to benefit patients in terms of the tailoring the specific treatment for different subtype of patients. So I hope to convince you that there are tremendous inter-patient heterogeneity. What about intra-patient heterogeneity? So our lab is one of the groups to define so-called cancer stem cells in bladder cancer. And here it's showing you that we use a reporter that we can label K14 positive cells in red, which mark, you can see we can fax flow cytometry purify them. And then you can see that by mRNA expression showing the fidelity that you highly express K14 and very low expressing the differentiating marker uroplactin. So this is part of the CD44, CD49 double positive cancer stem cells that we would previously characterize, but don't have time to get into today. And here just show you functionally these K14 positive stem cells enriched for the sphere forming ability. You can see that on the left panel here, and then also as well as the enriched for in vivo xenograft formation ability. So the two major criteria for cancer stem cells in vitro and in vivo. And I don't have time to show the data, but they can fully differentiate into other cell types within the tumor, including intermediate and differentiated cells. So with this intra-tumor heterogeneity kept in mind, so how is it relevant to the therapy response and treatment? So before 2017, for bladder cancer, as you know here in the audience, the neoadjuvant chemotherapy and radical cystectomy remained the standard of care. And while MVAC was the earlier regimen, gemcitabine cisplatin combination is the most commonly adopted combination due to the lower toxicity. And you can see that this graph here from showing here a meta-analysis data combining 11 trials and more than 3,000 patients, showing that there is definitely a modest but significant clinical benefit, improving patient for about 5% improvement in the overall survival. However, there is still definitely room for improvement, and which is the first part of the program here that I want to show you. So this is the classical mechanism of action for gemcitabine. That is a prodrug, inactive, transported into the cells and then metabolized into triphosphate form that bind to DNA. And there are two mechanisms that they bind to DNA and stop DNA replication, and also stop the ribonucleic reductase, which competes with the DNA synthesis, because this is gemcitabine is in fact a cytidine analog. So there are two major mechanisms that working on this drug. And cisplatin, as you know, that it forms intrastrain adducts and interstrain adducts, which also impact replication here. And to this audience, I don't think I need to mention the mechanism of resistance. So there are several of them. Sorry, the point of that. So so you can see here that, for example, there is for example, decreased drug influx through the reporters, or increased efflux of these multiple resistant drugs transporters, such as the ABC transporters. And in fact, stem cells, cancer stem cells have been known to overexpress these ABC transporter or multi-drug resistant transporter that increase drug efflux, therefore intrinsically induce resistance through this mechanism. And obviously there is like increased DNA repair as well as increased tolerance that would play a role, as well as overexpressing anti-apoptotic pathway or inactivating cell death senescence. That's the so-called classical mechanism of actions. So in the past decade, there's, as I alluded earlier, there's data in the solid tumor, primarily in breast cancer, and later on many other different types of cancer, showing that solid tumors, these so-called cancer stem cells are intrinsically resistant to chemotherapy. So how are chemotherapy commonly studied in the laboratory? So usually investigators put cells in culture for long-term selection for several months, leading to these so-called resistant clones, and they will compare the resistant clone with the parental clones, and then look at the downstream analysis that I talked about earlier. Or they use single treatment of chemotherapy or single dose or maximum one cycle, and then look at downstream analysis. And to this audience, as you know, that in the clinic, chemotherapy are not treated in those settings. They are in fact treated with multiple cycles with gap period in between for the bone marrow stem cell to repopulate during the gap period to reduce toxicity. So we think about that, keep that in mind, and we thought if bone marrow stem cell can repopulate during the gap period, if there's cancer stem cells, they can likely repopulate and contribute to resistance. So that's the hypothesis in mind when we first started the study. So this is a study performed by my former student and my fellow Jing. She went on to Genentech as a postdoc, and now a principal scientist in BMS. So we've obtained primary xenograft from patients that do not respond to chemotherapy, and then put them in mice as at that time, most clinically relevant models. And you can see that, to our surprise, after one cycle of chemotherapy, the patient xenograft that do not respond to chemotherapy in the clinic seems to be responsive. But it's not until second, third, and then fourth cycle of chemotherapy you see this manifestation of chemotherapy resistant phenotype. And this phenomenon is now reproduced in multiple xenografts, showing that maybe because gemcitabine is cytidine analog that incorporate into proliferating cells. So we will be interested to see if this kind of response also hold true in other cancer type with other chemotherapy regimen. And most interestingly, for the sensitive tumors, instead of the tumor going down like one would expect it, they actually go like a sigmoidal type of curve, which is another topic of interest. To summarize our mechanistic data, so we found that similar to a wound injury, where injury-induced cell death leading to the recruitment of these quiescent stem cells from the bulge region, this is in the skin to repair. Chemotherapy also induced programmed cell death, but also severe injury in the tumor. And these dying cells release factors that play a role in impacting the residual surviving cancer stem cells, recruit them into proliferation, and with multiple cycles of chemotherapy, manifesting the resistant phenotype that we just shown earlier. And it show you some key data to back this up. So you can see here, this is chemotherapy treated with overtime cells starting to die over time, shown by the increase of caspase-3, a marker for apoptotic cells, as well as COX-2, the upstream enzyme that metabolite arachidonic acid into PGH2 and into PGE2, and you can see that there's a reduction of induction of cell death correlate with the induction of release of prostaglandin E2 into the supranucleus, which is a very strong mitogen, known mitogen to impact, which we later shown to be impacting cell proliferation. And that this is a few years ago, and now we know that programmed cell death, there are many different forms of cell death. And we have looked at, for example, a caspase-1 dependent so-called pyroptosis that involved the dimerization of caspase-1, which is a major substrate for one of the major substrates pro-caspase, pro-IO1 beta that can be cleaved into active form, as well as gasdermin that are cleaved to form pores, allowing active transport of nutrient, the active transport. So here you can see that with chemotherapy induction, there's a cleaved caspase, active upregulation of caspase-1, leading to cleaved IL-1 beta as well as the histamine D. And also other form of cell death such as necroptosis, which is a RIP1 dependent driven, leading to phosphorylation of MLKL. And you can see that even gemcitabine as a expectant treatment, there's a mixture of apoptotic, pyroptotic, and necroptotic cell death. And these are electron microscopy showing that in the culture, there's a mixture of apoptotic and lytic cell death. And this is work driven by my student Kasu and his summer student, Amene. So here, I just want to show you that cell death-induced release of PGE2 is dose dependent. You can see increasing dose of gemcitabine cisplatin lead to increasing dose of PGE2 release. And this is also a generalized phenomenon. And when we look at multiple cell line here, three dots, repeats of one cell line, and there is a correlation between cell death and release. So it's a generalized phenomenon, and now we also generalize into different treatment regimen, as well as pancreatic cell line as well. So I hope to convince you that cell death leads to release of the mitogen. And here now we try to use functional assay to show like what's the consequence of that. So we remember I talked about the sphere forming assay, which quantifies cancer stem cells. You can see here that we take the supernatant from chemotherapy treated cells and then put them on the sphere forming assay, comparing to the gray bar here to show a significant induction of sphere forming ability, which is surprising at the time because we didn't expect chemotherapy treated supernatant lead to the significant induction of spheres. And this, you can see this is significantly downregulated by addition of a neutralizing antibody, and then the celecoxib, the COX-2 inhibitor, and in combination significantly reduces sphere forming ability compared with people. And in vivo, we also show that the similar phenomenon. So this is a so-called classical assay where we double label using IDU and CODU. The simple form is to basically using IDU to label so-called label retaining cells or stem cells, quiescent stem cells in vivo. So which you can see this is in green here, marked by green. And then we can label the CODU and then look at after chemotherapy how it changed the incorporation of proliferating cells in vivo after chemotherapy at different time points. So you can see the label retaining cells mutually exclusive to the proliferating cells in red here. But interestingly, after 6 hours after chemotherapy treatment, you can see significant reduction in these red cells, but which is rebound. You see this so-called this repopulation or rebound after 12 hours, which is marked in neighboring cells, and see that the green and red are co-labeled as yellow, suggesting that the slow cycling cells are being recruited into proliferation. So hope to convince you that both in vitro and in vivo chemotherapy lead to reduction of proliferating cells, but followed by a repopulation of quiescent stem cells. So then we turn to back to this xenograph, and then we add the drug celecoxib. It's known to target the upstream enzymes COX-2, and you can see here that it significantly sustained the response. And when we look at the content of these tumors, you can see those that are treated with GC chemotherapy alone significantly filled with CK14 positive stem cells, while those with combination therapy are significantly reduced. And this can be reproduced in other models. One very common T24 model where it metastasized into lung. You can see the primary tumor showed similar response. And in the lung lesion, you can see chemotherapy, in fact, has a significant effect in reducing the metastatic burden, but the combination therapy have a more significant and drastic effect. So I hope that this part of the talk, I convince you that chemotherapy is initially effective in reducing tumor burden, but cell death release PGE to play a role in repopulating the quiescent stem cells. And we have an FDA-approved drug to block this phenomenon and try to sustain the response. Oh, this is exciting new data showing that at that time, a few years ago, we don't know what type of quiescent stem cells is driving this phenomenon. This is using single-cell RNA-seq data from another syngeneic model. You can see that there are different clusters of epithelial cells. And you can see that one cluster that are CD44, CD49, and K14 positive that I mentioned that are proliferative. And we might find another population that is induced by chemotherapy that might be the quiescent proliferating quiescent population that lead to proliferation of the surrounding cells. So that's a project in active investigation. But at that time, we were very excited to see in a canine, in another model, where they use another non-selective celecoxib inhibitor and was able to induce chemotherapy response by over 30%. And we have a phase 1 clinical trial started to look at the effect of celecoxib with chemotherapy. However, as you mentioned, have you known this audience, that there's one major technical limitation. Even patient-derived xenograft was one of the most clinically relevant model at that time, but they were studied in immunocompromised setting without taking into account the immune microenvironment, which become very important right now since the expedited approval of immune checkpoint therapy in 2017, which we will now talk about. So this part of the talk, I hope to convince you that although we were trained to induce programmed cell death and to study that, there are interesting new biology. For example, the first part of the talk was showing that cell death induced compensatory proliferation and repopulation. And I hope to mention in the second part of the talk that there are also immunomodulation that are important. So to this audience, I don't think I need to introduce that in 2017, there's FDA expedited approval of immune checkpoint therapies for bladder cancer, as well as many other solid tumor types. So it's bladder cancer is considered a high mutation burden tumor that show response. However, it's only about 15 to 30% of patient response. 70% of them are considered non-responders. So for the trainees, how it works is that the T cell require a so-called signal 1, which is MHC class 1 activating T cell receptor as a signal 1, as well as co-stimulatory molecules binding to the CD20 as signal 2 and their cytokine as signal 3. But cancer cells develop a resistant mechanism by overexpressing PD-L1. And now we also know that stromal cells, as well as myeloid cell, also can overexpress PD-L1, which bind to PD-1 on T cells and leading to the blocking of signal 1. And T cell also overexpress CTLA-4, as which competes away the co-stimulatory signal to block signal 2. So this class of so-called immune checkpoint blockade therapy utilize anti-PD-1 or anti-PD-L1 to, as well as CTLA-4, anti-CTLA-4 to unleash this inhibitory signal and unleash T cells so they can become reactivated. So for bladder cancer, investigators have been trying to use chemotherapy in combination of immune checkpoint therapy in hope to enhance the therapeutic response. However, two highly anticipated phase 3 trials recently combining chemotherapy in immune checkpoint therapy did not improve the overall survival. This is a table taken from one of the trials. You can see that the combination treatment did not improve the overall objective response over chemotherapy treatment alone. And in fact, the combination treatment seems to nullify the durable response to immune checkpoint response as well. So in retrospect, it might seem a little bit counterintuitive because cytotoxic chemotherapy are historically known to induce immunosuppression or myelosuppression. So why would a combination with immune checkpoint therapy improve the overall response? So when we dig deep a little bit and looking at different classes of chemotherapy, in fact, we found that certain drugs, chemotherapy drugs, are able to induce so-called immunogenic cell death. For example, some of which paclitaxel for breast cancer, oxaliplatin for colon cancer, and other drugs. However, cisplatin or gemcitabine are not among the chemotherapy known to induce so-called immunogenic cell death. So what we did here is that we performed a mass spec proteomics to analyze the supinate and beta after chemotherapy treatment, and we found that very interestingly, we found a class of structurally unrelated proteins illustrated here, and in fact, they are important molecules that are, for example, like keraticolin, which is an important protein that translocated from the ER to cell surface to serve as a so-called eat me signal. And then other proteins such as T-shock protein 7090 and HMGP1 that are known to be so-called damage-associated molecular patterns or danger signal that engage pattern recognition receptors on antigen-presenting cells such as dendritic cells. So the so-called immunogenic cell death is classified by the release of these DAMs into this to engage activation of dendritic cells, leading to the priming of T cell activation. Right. So this is a little bit surprising because if gemcitabine and cisplatin are not known to induce immunogenic cell death, this is a dogma suggesting that if you have these factors being released, you should induce immunogenic cell death. So we verify these results by flow as well as by Weston. So what we did is we turned to a classical assay to look at immunogenic cell death. So this assay works by, so we treat cells in vitro, induce a so-called IC50, and then we inject into the left flank of the mice as a vaccine. So then we come back 7 days later to inject on the right-hand side. So if this is a so-called ICD-induced drug, it will prime a immune response and reject the tumor on the right-hand side. And you see there will be tumor-free mice, right? But if it's a non-immunogenic agent, then it won't be able to reject the tumor upon re-challenge, and tumor will grow. And so we use it as an assay to look at heme and cisplatin, and you can see that they are non-functionally, they are non-immunogenic drugs compared to a positive control. However, they were able to release these DAMs. So at that time, it was puzzling. But we also remember that there is COX-2 induction in this model as well as PGE2 release. So we hypothesize that additional to what the dogma is thinking, that DAMs are important for determining immunogenic cell death. So PGE2 might act as an inhibitory DAM to keep the balance because it's also heavily released by these cells. And if we tip the balance by using drugs such as celecoxib to block the PGE2 release, we might be able to tip the balance and able to activate dendritic cells to prime an effective CD8 positive T cell response. So that's the experiment we did. We used celecoxib treatment. You can see that it effectively rejects tumor. as well as using a genetic knockout of COX-2. You can see even further reduced. And we use a CD8 antibody depletion to show that these phenomena are dependent on the CD8 positive T cells response. So then we next want to look at the mechanism. So we adapted the same assay into a so-called Footpath assay. So now this work is driven by Kazu and senior fellow Fotis in the lab. So we were able to do the same assay in Footpath and then look at draining lymph node to look at dendritic cells now, the primary, because stems activate the pattern recognition receptor on dendritic cells. And you can see here that upon celecoxib or the genetic modification of COX-2, CD103 positive dendritic cells, this frequency is significantly induced. And not only that, but signal 1, 2, and 3, as well as a lymph node trafficking signal, was also significantly induced, demonstrating that the dendritic cells are being activated by this so-called IDAM blockade therapy. So I hope to convince you that when we block IDAM, there's a dendritic cell activation. So now we want to look at how dendritic cell activation lead to T cell response. So again, here now we use at a different time point. You can see that there's induction of a Tbet, which is a TC1, so T cell 1 polarization that are important for anti-tumoral response, as well as interferon gamma, as well as which is important for T cell activity. And then the so-called T regulatory cells that are these inhibitory T cells reduce, which and CD107, another marker for activity of T cells, is being reduced. So further, so I hope to convince you that upon IDAM blockade, there's deep dendritic cell activation followed by a T cell induction. And clinically, there are different types of tumors that are being classified for inflamed, T cell inflamed, immune excluded, or immune deficit, that there are association with the clinical response, right? And the T cell inflamed tumors are more respond favorably to the PD-1, PD-L1 inhibition, while the other two types are associated with less response. Currently, the most model in the field are T cell response. However, more than 50% or about 50% of the tumors, at least in bladder cancer, are immune excluded. So here I want to show you that we have developed a model that this is representing the entire tumor. Marked by red here are the stromal cells, and green here is CD3 positive T cells. And you can see the T cells are being excluded in the periphery or stuck into the stromal regions here. Another more clinically relevant tumor. And we in Fotis use this model to look at PD-1, GC chemotherapy, and combination therapy. And you can see that they all stack up here. So this is a very very resistant model to single treatment of standard of care or even combination, recapitulating that phase 3 clinical trial. Here, when we combine GC with celecoxib, you can see significantly improve the response. And then with combination of GC celecoxib with PD-1, further enhance the response. And data here showing that it correlates with the activation of T cells, as well as TC1 type of T cells. And more interestingly, is the GCC or with celecoxib treatment can mobilize T cells into the core. You can see that with chemotherapy toward the core, the T cell density start to go down. But this combination treatment sustains the T cell activity and infiltration into the core. And when we use an antibody to deplete, you can see that there's a tumor difference suggesting the T cells are functional in this treatment. And this is in the combination treatment with and without the IDAM blockade. You can see the combination treatment, there are increase of T cell with the PD-1, there are increase of T cell infiltration, but they are still stuck out in the tumor periphery or in the stroma. A combination treatment with IDAM blockade significantly lead to the infiltration of T cells. And this is clinically relevant because we utilize a MVIGA trial where we have pre-treatment tissue from a PD-1 treated patient. And you can see that PTGS2 or COX-2 level significantly associate with the non-responders, and then PTGS2 high correlate with the poor overall survival in the immune checkpoint response. So I hope to have convinced you at this part of the talk that PGE2 acts as an IDAM, which balance the immunogenic or tolerogenic response. And when we have IDAM blockade, we can sensitize immune checkpoint resistant and combination resistant preclinical models into enhanced therapeutic response. And this phenomenon is generalized, not just to the chemotherapy treatment setting. You can see that radiation thought to be a more immunogenic drug, in fact, suppressed COX-2, the IDAM, and I don't have time to show the data, but they also show the release of DAMT. And in collaboration with another investigator in NCI, where she's very interested in cabozantinib combination with ICI, we can see that cabozantinib is in between gemcitabine and an immunogenic drug. So there might be opportunity to introduce IDAM blockade to other therapy, such as targeted therapies. And most excitingly, we are now setting up an MTA with a company, Tempest, where we can also block, use an EP2 and 4 antagonists to block the downstream of EP receptors, specifically blocking those receptors that have tumor promoting or immunosuppressive role, leaving the other receptor intact. So this is another very interesting preclinical and clinical directions that we want to take. So I hope that this part of the talk that I convince you that while most chemotherapy or anti-cancer therapy in the field, we want to focus on targeting cell death, but cell death induced release of PGE2 can act as a mitogen to induce cancer stem cell repopulation. And there are other factors released, such as STEMs, that is important for modulating dendritic cell and T cell response. And PGE2 acts as an inhibitory dam together as a non-classical mechanism of resistance. And if we abrogate that, we can enhance chemoimmunotherapy response. So I think we can end here, or we have some other data showing you that there are different levels of, obviously, other levels of regulation. Maybe very quickly, I think. So as you know, that it's not simple, that one drug, I'm very highly anticipated with that one drug, but in the tumor microenvironment, the green cells again are the T cells. You can see there's a lot of myeloid cells, even in the so-called immune excluded tumor, particularly myeloid such as macrophages and neutrophils. Here we are staining neutrophils. As you all know clinically, high neutrophil to lymphocyte ratio correlate with poor prognosis in many settings, in both treatment and treatment-naive setting. And we are at the verge of characterizing these neutrophils and neutrophil heterogeneity. And we found that they are suppressive. They can block T cell activation in vitro, and in vivo, when we block the neutrophils coming in using a drug to block infiltration in the tumor, you can see there's a significant response that correlates with T cell activity. So this is another level that we are looking at the immune microenvironment, characterizing these immune excluded tumors, looking at their different types of neutrophils that might have pro and anti-tumoral roles, and can we flip the tumors that have the pro-tumoral neutrophils into anti-tumoral neutrophils as another strategy for enhancing therapeutic response. And we have another part of the program that we don't have time to talk about is how therapy may regulate regulate fibrosis, the stromal microenvironment, which we mentioned about the immune cells are being stuck there. And in fact, in the chemo-resistant patients, you can see a significantly enrichment of the fibroblastic activation signature that are heavily infiltrated with collagen. And we have a program looking at collagen signal, how that regulate metastasis. You can see over there with no collagen, this form a sphere that I mentioned earlier. With collagen, you see this very interesting sprouting that looks like they're invading. And we have recently found that also tumor cells with collagen receptor overexpression, they go to a very interesting metastatic niche in the airway smooth muscle cells that are collagen rich, that are in contrast to the typical foci that we know. And those are active under active investigation as well. So I hope to convince you that we are doing highly translational program, but what is lacking right now is I'm highly convinced that before we go to phase 3 clinical trials, we need more early phase trials. And then with the tissue coming back to the lab to look at and look at generating clinical relevant hypothesis, and then this cycle fine tuning before we go to large scale clinical trials. And obviously I'm a big fan of getting more involved basic scientists to get into this translational research. And I hope to convince you that PhDs can do highly translational clinical research. And I think we need to engage more students, the next generation of students, to engage in translational research. And I'm actively also, since I don't see patients myself, but I have a great honor to be working with the patient advocacy program with the ACR, where the patients are really involved in motivating us to do translational research. So I think I would end here. I have acknowledged most of my team members, the funding source, and I'm most proud for me is the trainees, the training grants for the trainees. And I thank you for your attention. I'm happy to take any questions.
I want to say thank you. That was a really phenomenal presentation and really very important work. I was intrigued by the finding of the COX-2 inhibition modulating the efficacy of chemotherapy. I'm wondering if there's any observational epidemiologic data looking at that. I wonder if it's a way to, there are a number of patients who probably are on COX-2 inhibitors or NSAIDs. Do you think NSAID exposure would be sort of an undifferentiated NSAID would be sufficient? Has anyone looked at that?
So in fact, I mentioned to you earlier that I'm working with an investigator at Dana-Farber. So he's very interested and he's looking into the NSAIDs and then pulling a data set. And then I believe he even have an immune checkpoint response cohort. So he's analyzing the data, and there's some initially interesting data that I would love to share with you afterwards. And then if you have other cohorts, I would love to work with you to look at treatment naive versus treatment setting, and then different treatment setting to see if there's any association, and whether we can get those tissues back in the lab and look at these type of phenomena. That would be fantastic.
Yeah, I think there's a real opportunity there, especially there are some ways to look at it. One of the challenges is exposure, right? Because if it's not in a prospective randomized trial, its exposure levels may be different, but there are some techniques to account for that.
Yeah, that's correct. And also, I think the timing, I wouldn't be too discouraged if we didn't find any association, because those are continuous treatment and you cannot control when the timing of the drugs come in. As you know that there are other studies looking at sequential treatment and when the drug needs to be applied. I think in this case, we need to saturate the patients with NSAID inhibition before you start chemotherapy. Otherwise, the PG2 is already released into the tumor microenvironment and might be too late to block the effect. And also, we have some initial findings, maybe that if you saturate this drug too much, there might be a negative feedback to activate this pathway in other T cell types, such as myeloid cells and fibroblasts. So, but it will be very interesting to look into those. Yeah.
Question, Stan Petrolak, good morning. Great talk. So you cited, of course, the atezolizumab trial, and then there's also the Merck study with Pembro that's showing very, very similar results. May not be exactly the same in the PD-L1 positive with atezolizumab, and survival data is still pending, but that's giving drugs all up at the beginning, all three. How do you, in your model, I guess, think about the issue about sequential therapy? So we have two studies. We have the Javelin trial, which randomizes patients who have responded to chemotherapy to checkpoint versus observation, showing a survival benefit. And then the study that was with nivolumab in the adjuvant setting post-cystectomy, where if you look at the subgroups, the patients who benefited the most with adjuvant checkpoint therapy were those who received chemotherapy. So is there a time limit in terms of your expression of PG of those particular agents you mentioned? Or is there some other biological phenomenon going on that explains why we're seeing survival benefit and a disease-free survival benefit in sequential versus the all-up?
Yeah, I would love to talk to you afterwards in detail about this sequential regimen. But since you're expert in this field, right? So, but obviously we think there is a timing for giving this anti-inflammatory drug, because I think we need to block the release or block using the antagonist to block the downstream, because activating dendritic cell is very important for priming the antigen-specific T cells response. Yeah, I'd love to talk to you more afterwards to dissect that out. Did I address your question, Marcia? I guess. Sorry.
For bladder cancer services, do you think it's going to be more innate or an adaptive response that's going to be most helpful?
I think, first of all, I think there's definitely direct effect of drugs to the epithelial compartment, right? Which I elucidated in the first part of the talk. But you can see in the later part that I alluded to, we wanted to skew the adaptive, the response into an adaptive, avoiding the innate inhibitory effects. But nowadays there are other innate cytotoxic. I think you're referring to the cytotoxic innate. Is that what you're alluding to?
The macrophage need that's its T cell currently.
Yeah. So I think we wanted to obviously modulate the immunosuppressive innate response to skew it toward adaptive response. But the issue is there are other innate response that are beneficial. So how do we avoid reducing those beneficial effects while skewing toward the beneficial effect? That's the $1 million question, I think. But very good question.
So for For high-risk, non-muscle invasive bladder cancer that's refractory to BCG, we'll transition oftentimes to intravesical chemotherapy. And there's a significant response rate for most patients for a period of time, a year, for instance, and then they develop resistance despite maintenance therapy. Is it reasonable to think that similar mechanisms of action of resistance may be active in non-muscle invasive bladder cancer that's localized? And if so, could you imagine a scenario where we could use even intravesically celecoxib to rescue patients?
Yeah, outstanding clinical observation. If you have, and I think those patients are treated with mitomycin series, I think you're referring to intravesical
Or gemcitabine, docetaxel.
Really? So then, I think you probably have sequential tissue from those patients, and definitely if it's gemcitabine, we haven't looked at mitomycin C per se, but we look at gemcitabine and other chemotherapy drugs as well as target therapy and radiation. So we believe this is a generalized phenomenon, and definitely we can have the tissue to address that and to understand it and potentially use this combination as an intravascular to prevent the recurrence. Because as you would imagine, BCG is producing a massive immunomodulatory response, and then it might tip to this later stage, which can be preventable. That's very exciting. Love to hear more about it. Great potential. Well, Dr. Kim. Hey.
This is Isaac Kim.
Hey, Professor Kim.
Yeah. Thank you very much for outstanding talk. I just got a quick question about your cancer stem cells work. I wonder, your work about the stem cells somehow being woken up with the chemotherapy. That observation, can you extend in some way to prostate cancer cells where we have these dormant cells that some of the early studies from Washington have shown that up to about 40-50% of patients who are undergoing radical prostatectomy will have a stem cell or some sort of tumor cells in their bone marrows. So the question is are they dormant for a while and all of a sudden they're waking up, and what the potential signal may be? Does it have anything to do with, can that be extended to what you're seeing with the stem cells and the chemotherapy that you're using?
Yeah, definitely. I think that's a great question. Another great question in another cancer type. And I think there's a lot of parallel between especially pathway regulating the dormancy of cancer stem cells in different tissue types. And most recently, depending on how you define them, but these quiescent and proliferating stem cells, they actually have different response to NK cell mediated immune evasion. So I really think that, but there's a lot of arguments whether you call those dormant cells or when they are inhibited by the immune system. But I think it's very likely that these dormant or cells that are being kept in check by where they are sitting there for not sitting there, they are not manifesting the clinical symptom. They are being kept in check by NK cells and other types of cells. And then when they have to overcome this suppression or evade this suppression to go into expansion and manifest the clinical symptom.
Got it. Thank you.